All right, good morning, everybody. Welcome to today's episode of the Mind-Soul Connection. I'm Jaime Blaustein, the co-host and CEO of the Sylvia Braffman Mental Health Center, here with my other co-host, Ben Braffman, Chief Clinical Officer, and the Wolf, as we call him.
Thank you.
Nice to be with you again.
You too,
It's we're rounding the end of the summer here, and this season or whatever, the last few episodes have been a little bit more lighthearted in general.
Yeah.
And we like to have a good mix of fun with, intellectual, with just different angles. There's so many things that we can talk about with respect to mental health and addiction, and so we like variety, and I really like to show all the different, angles that we have perspectives from, as people who have gone through mental illness and addiction, as clinical experts on it, and as human beings who, like to talk about things like movies and
Sure.
Whatever prism we're going to view it through that particular day. So today I want to dig into what makes a good treatment center. What separates the winners from the rest of the pack? We have a lot of experience, and our experience is a little bit different, right? You have experience as a clinician.
Mm-hmm.
I mean, you've done everything in behavioral health, right?
Mm-hmm.
Where you were a PhD, right? So
everything.
You've been a clinical mind, you've been an operator, you've been an owner. And I have been an operator, I guess, via, the last 2 years being CEO of Sylvia Braffman.
Mm-hmm.
But most of my experience is actually as a patient.
I was just going to say, both of us have been patients.
Right.
So, we have that experience too going for us.
Yeah. And that's actually one of the things I love about my current role. I never thought I was going to be a behavioral health guy. I was always pretty content with digging into mental wellness and recovery in my personal life and having that run parallel to my career. And I was on Wall Street and I like business, and I went to business school and all of that. So I never really thought those two lives would combine. And it's a very awkward combination of altruism and business. But one of the things that I really love is, you run the show clinically. And so I can sort of like not have to worry about that to a large extent. I'm running the business, but I'm also a patient advocate in that I can wear the hat of the patient. And, from behind the scenes, sort of like, chime in on what suggestions I have to maybe tweak some of the operational things. So a silly example, but this was a couple months ago. I remember I saw that, it was the Sunday, and that's the one day where we don't do treatment. You consider it treatment, right? Because you always say they're in group when they're not in group, right?
They're always in group.
The van,
always in group,
right? But it's the day that they don't come to the clinical center, and I saw that they had gone to the beach at like 4:30 p.m. And that, for some reason, struck a chord with me because I felt like I was a patient. I was like, why are we going at 4:30? Why don't you get to the beach at 12:30 or 1 o'clock?
Right.
So like little silly things like that, I like to chime in.
Yeah.
But then I've seen, the completely opposite side, not even the patient perspective, not even the clinical, but the business side. And I don't want to focus too much on that today.
Yeah.
But there's certainly dimensions of the business that bleed into the clinical and the patient experience, and that play a role in the sustainability, because if you can't stay open, you can't help people, right? So
that's true.
I'm very interested to hear your take on this. I know you have strong views on what the right protocol, what the right clinical approach should be, and I have my views as well. And so what I'll say, just again, my perspective in terms of the number one thing is the clinical backbone of the program. I've said before, I wouldn't have done this with anybody but you.
Thank you.
Look, you can have all the bells and whistles and the nice pictures on the website, and I think there's some value to that. I think it helps get people, in some cases, if they're not fully surrendered or they're on their way to being surrendered, that, okay, it couldn't hurt to go live in a nice home or at a nice facility, right? But at the end of the day, clinical drives everything else. Clinical drives the patient's chances at getting better. It drives the business. And so, as an owner, right, I have the opportunity to allocate, right? It's like, where do I want to invest? I can invest in marketing. I can invest in operations. I can invest in, and we've decided to go heavy on clinical, right? I think a greater percentage of our spend is allocated towards clinical labor specifically, for that reason. And so, we just, without that, I just think, what are we doing here, right? So that's just, my perspective. I know family involvement is going to be something that you likely talk about. So sure. I'm just going to turn it over to you. Like, what do you see as the key differentiators of a good treatment center?
So I appreciate that. And thank you for the compliment about, wanting to do it just with me. I jotted down some notes. There's so many factors that go into, what's a good treatment center, and there's a lot of bad actors out there. And as over this past 2 years, you have come to know, and those are the ones, unfortunately, that make the news. The one thing I want to say before I get into, my top 10 list, so to speak, is I'm a guy who, and I'm a treatment person and a licensed professional. I am very old school. Group is group, and it's everything, because to me, the power of group, power of family, and that's what group is really what makes the difference. I am not somebody who's into massages and chocolate truffles and turn down of your blankets at bedtime and having a maid and all the stuff, and these kind of like, I don't know, camp type of atmospheres. Let's give you, vitamin therapy. I'm not that person. I acknowledge the fact that from a business perspective, sometimes we have to keep up with the Joneses, but I'm just not that person. Like, treatment is treatment. So in terms of what makes a good treatment center, first and foremost, I want to hone in on the clinical aspect of it. You don't have a good clinical program, you don't have a program. You just alluded to it. So you have to have a educated clinical leader, somebody who has been in the space probably at least 5 to 10 years. And then from there, what you want to have is you want to know what you are. You want to know what your clinicians can do. And I've talked to you about this before, and I think it's worth discussing here, is that I kind of view, treatment as, metaphorically, we're protecting people from themselves. We're protecting people from outside bad things happening. Right. And so, I like to use, metaphors, but, the movie Magnificent Seven is something that I've used and weaved into the clinical program. And that is that, a group of 7 completely different people came together, and they basically held together this small Mexican town from these bandits. And they went through their, whole process. They had difficulties. Some of them were killed. But this group stayed together. And to me, to have clinicians who each one has a specialty. One is good with the 12 steps. The other one is good with the high acuity of mental illness. Another one is good with women. Another one is good with men. Another one is good with borderline personality disorder. You got to have shtick. You got to have your thing. Yeah. And so a good clinical supervisor does that for the staff. So
can I ask you something? So, well, first of all, I think you've done an amazing job of gathering the right team at Sylvia Brathman, because you can look at most of them and know, okay, that's the guy or the gal for XYZ, right?
Exactly. And let me just say this. Sure. So I'll walk around the treatment center and I can look at a patient and I'll know who is there or her therapist is. Yeah. Because of that.
Yeah, pretty intuitively. I'm there oftentimes when you allocate a new patient to somebody. So do you prefer, and maybe it's not either or, right? I this is a bad habit I have. I like to put things in a box, right? So I used to always say, on Wall Street, right? I like working with well-rounded people or well-lopsided people, right? Like you're really, really good at one thing and maybe not so good at, but at least I know how to use you or utilize you, I should say.
Yep.
Or well-rounded, right? I mean, you can kind of do everything well. Do you need both, or do you like, because what you just said implies I like lopsided. I like somebody who I know what they are. They dominate that lane.
Here's what I need. I need both, but you have to have the clinical vision and the clinical supervision to make sure that if they're lopsided, as you said, then they need to do the job that you're asking them to do, not something else.
Right.
And that's where treatment centers fail, is they fail at the fact that, okay, we're going to hire this guy to be our schizophrenic guy, to deal with the high acuity mental illness. And then, oh, by the way, I want you to run an AA group.
Right.
No, that's not why he or she is here. And I've been very good at that, which makes for a very successful clinical program.
Yeah. So
I get excited about this because, again, to me, we're saving lives and we are protecting people and we're educating people, and it's actually a lot of fun for me too.
Yeah.
So strong clinical backbone, a must. A treatment center has to have an abundance of individual and group therapy. Group therapy should probably be 80%, 70 to 80% of what a treatment center does. To me, it's 100%, but that's me. You're in group always. If you're on the van, you're in group. If you're back at your, housing or whatever, you're in group. If you're in an outing, you're in group. Group is everything, but the individual attention, it's necessary for two reasons. Number one is that it's important for anyone, including us, to have somebody to talk to, right? You want to be able to talk to somebody. It's keeping up with the Joneses, individual attention. It satisfies the families out there, especially the moms. They want their son or daughter to feel special, and they are special, and we should respect that. So group individual therapy, an abundance of it, not just lip service to it. Need to treat co-occurring disorders. This is critical, and this is where a lot of treatment centers fail. They like the insurance part of it because it pays really well, right? Mental health or substance abuse or what have you, but they really don't have the horses to deal with it. But you have to have, if you have somebody who's addicted to heroin, marijuana, cocaine, alcohol, you have to have groups on depression and anxiety and bipolar disorder. They're fused together forever. And you have to have that education. You have to have that balance. When treatment first started, treatment failed because people were going 28 days to a rehab, and got sober, and then they left and they would relapse right out of the gate. Why? Because they didn't deal with their depression and their anxiety. They didn't take their medication. So treating the co-occurring is, you have to have that, not just, oh yeah, we have a group on depression on Fridays. No, I'm saying it has to be weaved into into the treatment center, into the treatment schedule. Long-term treatment. 30 days. For me, it's very simple. It's math. We get somebody who is, depressed for a long time and anxious for a long time, family issues, maybe even drug addicted, all that stuff. 30 days is not going to do it. 30 days of treatment at any level is not going to be successful. So I look at 90 days, long-term treatment or longer. Why? Because you can fake anything for 30 days. You can bullshit your way through it all. But at 90 days, we're going to find out who you really are, and we're going to be able to identify your strengths and your weaknesses. So long-term treatment is critical. It's absolutely critical.
It's funny you say that, because I just had a memory flash in my mind of, what it was at this point. It was 2010. So, 13, 14 years ago, I was in your treatment center.
Yeah.
I did fake it for 30 days.
Yep.
In fact, I remember I could not stay clean. I kept relapsing.
Right.
And so my stay kept,
pushing it back. Right.
But I remember, after 30 days at one point, you guys made me like the group leader. Right. So I was able to fake for 30 days, not only that I was doing well, but that I was, you know, deserving of like a leadership role within the community. And then obviously that came crashing down very quickly.
Right.
So I have my own personal experience with that. And I know you like to say, you know, 90 days is the clinically indicated duration of time in most cases. But obviously length of stay, really, I like to say it's a triangulation of three things. It's one, what's clinically indicated.
Right.
Two, the life circumstances of that person, right? Like, of course, you know, without the mental wellness, everything else can just fall by the wayside. But there are certain times where some people simply need to get back to work, right? They're on leave for a certain period of time.
Yep. Life gets in the way. Yep.
Right. And so you have to kind of, you know, back into something that makes sense in light of all those things. And then, of course, the financial aspect, right? Like, we're very, you know, dynamic with how we can get people help, even if the insurance stops paying or even if there are limited funds. But to some extent, that does drive it to a degree, right? So those are kind of the three things. But I agree with your clinical approach makes sense to me in terms of more is better most of the time. However, we don't want people to just dry out, you know? And I like to say the goal of treatment is not to sit there and white knuckle it and just kind of hide out, right? The goal is to serve as a bridge back to life, right? So we want people to take baby steps with support back into life. Like, why are we doing all this? We're doing all this so that we can be happy and useful and all the things that we want.
Exactly. We don't want them to hang on. We want them to thrive. We love the comeback, you know, but the comeback means that you've come back. Now you're ready to go to the next level.
Right.
So
it's definitely a delicate balance, right? Like, we want to find the right duration, but we also don't want to warehouse people, as you say, right? So
my fifth criteria, or, you know, on the list here is this is a big one. So many years ago, when I owned another treatment center, I had a program director, and he went into group and he did a mock funeral, and he had the patient lay in the middle of the group, and they did a eulogy, and they did all this stuff, and they talked about his life, and everybody's crying and, you know, emoting, and seemingly on the surface, a great group. They really, you know, got in touch with their feelings, and, you know, grown men are, you know, bawling, and, you know, the women are, you know, screaming, you know, the whole thing. And I was actually very upset. And I went to this program director and I said, "Why did you do that group?" He said, "I don't know. I just felt it was the right time." And I said, "So you didn't talk to anybody else?" "No." So that's the first indication. The second thing, as I said, "Where did you learn that from?" And he said, "Well, when I was in treatment, they did it to me in treatment, and it was effective." I said, "So you've really never done it before?" He said, "That's right." And so he just copied what he saw. So then the third thing, and this is the most important thing, I said, "What was the purpose of you doing that? Like, what now?" And he didn't know. He didn't have an answer. And that was my point. And you have to if you're going to do stuff, do not do it by the seat of your pants. Do not just make stuff up. It infuriates me. Everything that we do should be evidence-based. And everything that we do should not only be evidence-based, but there's a thing known as, you know, this informed consent. Every patient needs to know what they're getting themselves into. You know, they need to have the choice that, do I want to participate in a funeral? You know, that doesn't sound right to me. And they can have that discussion. They need to be empowered with that.
Do you think, I want to ask you this, because like my first reaction is, oh, that's creative, right? And is there a way that particular clinician could have done that where you would have said that's a good idea, right?
Yeah,
What would have been the difference?
Well, the difference is that we discuss it, right? We discuss it. We talk about, okay, what does this group look like? What's the purpose of it? What are we going to do afterward? And then let's say you're the patient. I bring you in and I'm going to say, "Listen, Jamie, we're going to do this group. You're going to be the identified dead guy, and we're going to do a eulogy. Are you cool with that?" 9 times out of 10, the patient will be like, "Hell yeah," you know, especially, you know, a little narcissistic, a little arrogant, you know, they kind of like the spotlight.
Right.
But usually it works out really well. "Hey, we're going to try something. What do you think? This is what we do." So when you go off the path a little bit, you want to be creative, be go crazy, right? But like, make sure the treatment center knows, make sure that your leadership knows, make sure that the patients are informed, get them behind it. I do a lot of out of the box stuff. I do a lot of out of the envelope stuff, but the patients know. I tell them before I do what I do, I tell them.
Do you remember when, again, I was a patient in Destination Hope. I couldn't stay clean. I mean, I had this whole story that I'll say for another day, but you made me carry an egg around. Actually, you gave me the assignment in front of my parents.
Good old Sylvia Braffman.
Yeah, my brother was like 10 at the time. Or no, he was like 8 maybe. And I named the egg, and part of my responsibility was to not let the egg die, right? Take care of it. And my brother, whenever we would talk for like the next year or so, he would ask me how the egg was.
So that's from Sylvia. That's my mother. Yeah, I mean, she did an experiment on us as kids. You know, we were her guinea pigs. You know.
Yeah.
So that was one of the things that she did, and her purpose was to teach us responsibility and be accountable and be responsible for something other than ourselves. It had mixed reviews, at the time. We're all different ages and everything, but ultimately it worked. In fact, I have the paper that she wrote on it. I think she submitted it when she was getting her master's. She had a nutritional counseling degree, so she submitted that, whatever. But I have that somewhere. But that was the purpose behind it, is to give somebody like yourself, who is, hey, it's about me. What about me? Right. And here it is, like an extension of you. And a lot of times patients fail immediately.
Yeah, I did.
And I would rather them say the truth, which is, I'm not doing this. I can't handle it. And why? And then discuss it in group. That is powerful to say to somebody who has a massive ego, for them to say, I don't know what to do. I need help, in essence. And that's the point, and that's what makes it powerful. But evidence-based stuff, you've got to use it. Not this. And that's again what gives behavioral health such a bad name, is these pseudo professionals. They go in a group because they saw it or witnessed it, and they just think they're so clever, and they're really doing more harm than good.
Yeah.
I'd rather have the steak than the sizzle, right? I'm not interested in the sizzle, right? I'm not some sort of magician, that I'm going to pull a rabbit out of the hat, so that you can be impressed with me. I'm actually going to explain to you the trick. Yeah. So evidence-based. Another one, number 6 on my list, is nutrition. It's amazing to me that patients come into treatment and all of a sudden they want their teeth cleaned. They're on a special diet. They're, I'm vegan. Were you vegan when you were like sucking down crack pipes and, shooting dope in bathrooms? So you were, sharing needles and whatever. So you gotta have nutrition. It's one of the 4 horsemen of getting back to the comeback is nutrition. I think one of the podcasts that we're going to do is on addictions, right? And food, I think, is one of them. And, food's a tough one. That's a tough one that I know I struggle with. I think that you struggle with, right? It's so important to be educated about what you're putting in your body. You have no problem putting, these opiate pills in your body, but you won't eat a stalk of celery with tuna fish. Like, what? You won't help yourself, so education on nutrition. And right after that is exercise, number 7. Got to exercise. I mean, this and I know this. If we exercise, we feel better. It's not even a maybe. It's we feel better. And I feel, from my own experiences, when I exercise, I feel more whole. I feel like I'm doing something. And it also, I think differently. Yeah. Like, I make better choices.
I've certainly fine-tuned my personal wellness package over the last 10 years. It's a non-negotiable for me at this point, and I have to do it in the morning, right? So I work out every morning, unless there's some whatever weird thing going on. And that is critical for me to, you could feel there's a chemical impact.
Absolutely.
From that.
Absolutely. No, it's a natural high
for sure.
And it's great. number 8 on my list is family and the family program.
Surprised that's not higher for you.
Well, this is just,
sure.
I can certainly put this
no
in
particular order.
Right. And so family is essential. Whether you talk to your family or not, whether you have a family or not, to understand the dynamics of family and to understand that you belong to something is critical to the greater picture. And so when families recover, when they get it, then the chances of the patient getting it increases probably about 70-80%. And in fact, I'll take it a step further. Success to me in a treatment episode is the family making healthier changes and doing things different. The individual is not ultimately the concern. It's the family. Now here's the rub, so to speak. The patient is part of the family. Right. So that's what I mean. It's like they're part of something. So if I can get the family back on track, going in the right direction, that'd be perfect. We've got something. We've got something very powerful. And there is a correlation between families who show up and participate in a family program. The identified patient gets better. There's a correlation. And the other thing is that the patient is not the problem. And that is another thing that treatment centers miss. They miss the boat on this. The patient is not the problem. They're merely a representative of the family and a greater problem that's going on. And once we incorporate that, we take judgment out of it. A lot of times patients, families drive up. Well, how much is it? Let me just write you a check. So you take care of Johnny. They come back 30 days later and they're like, how's Johnny doing? Well, he still needs more treatment. Wait, I thought you cured him. No, that's not how it works. Like, you got to be part of treatment.
Right. You always say it's a non-negotiable for us.
Non-negotiable.
I mean, we sort of view the family as being in a virtual wing of Sylvia Braffman.
100%. Right? And Zoom has made it more. Has made it easier to interact with families. All of that. You got to have a variety of modalities, Eastern and Western influence, but a variety. That being said, you also need to know your identity. So for example, at Sylvia Braffman, we know our identity. We're a cognitive behavioral treatment center. We are motivational interviewing, solution focused, and we are systemic in thinking, which is family therapy. Those are like the big 3. We have other modalities, of course, and we have, like I said, this kind of ties to the types of treatment we have with the therapists that we have, is that they have different modalities. Some are very clinical, like research based. Some are, more Eastern philosophy, your Zen, all of that stuff. Some are into nutrition and, well-being and vitamins and all that. Some of them are just hardcore recovering junkies and, go to meetings, shut the hell up, stay sober, So we've got it all. We've got the characters, and underneath it, the East and West modalities need to be integrated into it. And that also makes for a better experience, because, as you like to say, you throw the kitchen sink at them. One of these things is going to work.
Right. And that's the thing, like, different things work for different people. So for me, right, like we talk about, like, okay, let's throw the kitchen sink in terms of 5 lanes, right? Let's look at clinical, medical, psychiatric, spiritual, vocational, right? And different combinations are going to work for different people. So for me, I would say 90% of my getting better was the spiritual. Like, that's just what worked for me, right? And then maybe call it 5% clinical and 5%, medical, right? But for somebody else, maybe it's 30, 30, 40, or maybe it's 25, 25, 50. And I think a lot of that depends on the diagnosis, right? Like, you could say that medication is going to move the needle significantly more often for a schizophrenic versus a borderline, right? And so to find the right combination if you're going to fail in any one of those areas, fail fast, and then hone in on the stuff that's really, truly moving the needle.
That's right.
Is sort of what you're saying here. When you talk about East versus West, et cetera.
All of that. And then number 10 is social activities for the clients. This is a big one. This one is downplayed. This is the one that they sell to families, and it makes me upset. Here's the rationale behind activities. Okay, patients will use in treatment and use in general when two things happen: they're bored, or the activities are kind of dull. They're kind of not engaging, and also they're afraid. Okay, you take a grown man and put him on a trust walk, right? Or you have him, do some sort of, game, Pictionary, and, he's a 50-year-old guy, and maybe, leave me alone. I'm a business guy, and then all of a sudden, like there's another part of him coming out. You got to do activities. You got to keep the patients, you got to keep their brains going. Treatment is really hard, and you got to have fun while you're doing it. And that is non-negotiable. As far as I'm concerned, you have to learn balance. You have to, get over yourself. Don't take yourself so seriously. A lot of times we have young folks in treatment. They're bored. Yeah. I mean, that is one of the reasons that's a big reason why people relapse is they don't know what to do.
For me, like being sick, whether, for me, more addiction, but regardless, right? It's often the result of a lack of connection. So, I like to call it a state of separation. And so the antidote to that is connection. Mm-hmm. And so, in some ways it's underplayed. When I started going to meetings when I was, early on in sobriety, right? I'm a 12-step guy. And I think that was what moved the needle for me. But I will say that the fellowship, going to the diner after a meeting, being just hanging out in the living room, watching a game with the people in my, my sober living at the time, that was critical. Like the belly laugh that hadn't come out in so many years, the feeling like, oh my God, my social life as I know it is actually not only not over, but not even started. Right. Whereas when you're in it, you think, oh no, I'm going to be sitting in a room by myself, white knuckling it. I mean, that's a miserable thought.
It is.
I mean, I would rather be out there, to be honest. That's what it was. So the fact that, we can start to feel comfortable and realize that, okay, cool. It's not life minus the only, if you're an addict, life minus the only coping mechanism that I have. It's life plus recovery. And life plus recovery is connection with others and being able to suit up and show up for other people and not be so self-seeking in all of our relationships. So
100%. And it does boil down to that fellowship, family, feeling like you're part of something. It's all the same, right? It's all the same. You gotta stay connected. We're social animals. So if we don't socialize, then we are retarding, if that's the word, but we are really twisting, our destiny. Yep. And it's not going to be good. Of course, we're going to go back to our old behaviors. Yeah. Well,
this is a really solid list, and I'm very grateful that we have, you pioneering, the advancement of all of these different things into the Sylvia Brathwaite Mental Health Center.
Absolutely.
As you always say, we have more work to do. We're continuing to fine tune all this stuff. And there's you could probably go to 20 or 30 of these, but I do think that this really accurately summarizes what the winners, if you will, have at their centers. So, this has been great. Thank you so much.
Thank you.
Thank you all for listening and watching. Once again, you can find us on Instagram, YouTube, sylviabrathman.com, Spotify, all the places you watch and listen. Please like, comment, share, spread the word. Super appreciated. And we will see you next time.
All right.